Well, when Fabio Leo proposed me a topic for this presentation, and I suggested there is a Menger syndrome, I expected that the reaction would have been, forget it, it's a bagatelle. It was enthusiastic. So let me tell you why I selected this topic. The reason is that this is a paradigm, absolutely, of the interaction in between the heart and lung and back to the heart. And this topic covered the discussions for 1 century. Why? What is the reason of cyanosis in these patients? I would like to tell you this story and history. Let me start with the picture. So first, this is the sequence, the cascade that I would like to follow. The historical notes, the hypertensive pulmonary vascular disease, the discovery that there is a disease of the pulmonary arterial bed, the congenital heart disease are at risk of Menger syndrome, and finally the natural history. So let me show you first the picture of Victor Menger. He was living in Vienna, and he graduated in Vienna in medicine. And it was in 1897, at the end of 19th century, 1897, that he reported the case, a 32-year-old male that was cyanotic and died due to hemoptysis. Don't forget hemoptysis, because hemoptysis, when it happens, means that there is some vessel rupture. Okay, he did the autopsy, and what he described, a congenital heart disease characterized by ventricular septal defect, overriding of the aorta in the absence of pulmonary stenosis, as it is in tetralogy FLO, but with some atherosclerosis in the main artery and in the branches. Nothing else. But look at the diagram. I think it is very important here that you realize that you see here that he described with an arrow the shunt. And for him, the shunt in this patient, despite the cyanosis that he interpreted as a congestive heart failure, the shunt was from left to right. From still left to right. He did not surmise or suspected that there was something wrong in the distal pulmonary bed. So he was, by the way, for years, the doctor, personal doctor of the Archduke Ferdinand. Ferdinand was the one that was killed in Sarajevo in 1914 by a Serbian patriot. Okay, so what about the terminology? I would like to tell you the story of terminology because this is one of the most fascinating aspects of the disease. This is Maud Abbott. He was a pillar contributor on the history of congenital heart disease. He said that the Eisenmenger complex, he invented the term Eisenmenger complex. Complex consisting of 2 components of malformation, ventricular septal defect and dextroposition of the aorta without pulmonary stenosis and hypoplasia. So in other words, the term complex was a combination of 2 malformations, ventricular septal defect and overriding of the aorta. This term, she said, this is very important. I was unable to find an alternative in default of a vector to designate this unusual combination reported by Eisenmenger. But take in mind that if this was reported in 1936 in his atlas, but 12 years before, with this other author, Dawson, he said that the name should have been reported as a case of Eisenmenger. In other words, it was a morbus ceruleus, blue baby, with venous arterial shunt. So he suspected that there was a shunt from the right ventricle to the aorta, accounting for cyanosis, but the cyanosis was indeed a bit moderate in comparison with the tetralogy of Fallot. So let me show you some comments later on. So Fleming in 1997 wrote a book, a short history of cardiology, and when dealing with Eisenmenger, he said that Eisenmenger was puzzled by the cyanosis. Indeed, the surprise on that patient for Eisenmenger was the cyanosis, that is this man of 32. But this cyanosis was present not since birth, after birth, in the early childhood. He could not conceive that there had been a right-to-left shunt in the absence of pulmonary stenosis, so in the absence of tetralogy of Fallot. And he interpreted the cyanosis, indeed, as I mentioned before, as caused by venous congestion and congestive heart failure. Later on, Rashkin, look at here, in '82, Rashkin was the famous pediatric cardiologist in Philadelphia. Eisenmenger discussed neither pulmonary artery pressure, nor pulmonary artery hypertension, nor pulmonary arterial disease. He did not make histology of the lung at that time. The entirety of his attention, the pulmonary vascular aspect, was only the slightly dilated pulmonary artery, showing endoarteritic thickening in its inner surface, and along with the main branches, and nothing else. So, in Eisenmenger's mind was no idea what was the cause, or the right cause of cyanosis. Now we are well aware indeed that the problem is the distal pulmonary arterial bed. In other words, something was happening here due to the pulmonary blood overload with time, and this is the cause of hypertension, of elevated resistance there. I want to mention you that in 1947, we were born in 1947. I was born in 1947, indeed. And Leland Townsig, another mother of congenital heart disease and pediatric cardiologist at the Johns Hopkins Hospital in Baltimore, she published a congenital malformation of the heart book. This is absolutely a very famous, but it's rare. It's difficult to find this book, and I was really very lucky to read this chapter. Look at here. She presented a case of Eisenmenger complex, Eisenmenger heart. You see here Eisenmenger type, okay? And look at here, there is an died at 37 years of age. She was a female. You see enlarged pulmonary artery, and when sectioned, you see that indeed the aorta is overriding the ventricular septum, is arising mostly from the right ventricle. Okay, she didn't find pulmonary stenosis, and this time histology of the lung was performed. But look at here. Indeed, you see here that he said that it was that was not a case, by the way, in Johns Hopkins. It was a case in Brigham Hospital when she trained in pediatric cardiology there. The heart was enlarged. There was a large high ventricular septal defect, and the aorta was dextroposed and received blood from both ventricles. Received blood, not simply arising from. Received blood from the both ventricles. So the interpretation was indeed that the cyanosis was due because some blood was going from the right ventricle to the aorta. So, but look at here, the pulmonary artery was enormously enlarged. They did the histology, and there were remarkable changes in the lung which resembled arterius venous aneurysm. Unbelievable. They found disease at histology, but it was interpreted as a shunt in between the artery and the vein of the pulmonary artery and the vein. So this was another reason of the cyanosis. That is a bypass of the alveoli because of the arterius venous aneurysm. But when, listen, this is a nice story. When he was correcting the proofs of the book, a paper was published by Bing. Bing was a pediatric cardiologist at Johns Hopkins Hospital in Baltimore doing hemodynamic investigation in Eisenmenger syndrome. And look at here, I read to you. This is a physiological studies in congenital heart disease, results obtained in 5 cases of Eisenmenger complex. And this was published in the Bulletin of Johns Hopkins Hospital, unfortunately not existing anymore. Well, what he realized, he had shown that the pressures in the right ventricle and the pulmonary artery are abnormally high in patients with the Eisenmenger complex, dextroposition of the aorta, ventricular septal defect. Furthermore, the oxygen content in the blood in the right ventricle is higher than in the right auricle. And so there was a bidirectional shunt there, and the oxygen content on the blood in the pulmonary artery may be even higher than in the right ventricle. So these findings present strong evidence that the blood is shunted through the ventricular septal defect from left to right as well as from right to left. That was the first explanation, hemodynamic explanation of the Eisenmenger complex. So now the complex is anymore an anatomical complex, is an anatomo-physiological complex. Okay, so we are here later on. We are in 1956, and the definition made by Paul Wood, a very famous cardiologist in London, which, by the way, died suddenly at the age of 55 because of myocardial infarction and probably a coronary thrombosis because he was a strong smoker, unfortunately. Well, he said the Eisenmenger complex is a pulmonary hypertension with a reversed interventricular shunt. Forget the overriding of the aorta. What is important is the pulmonary hypertension, the present ventricular septal defect, and the reversed shunt. Later on, he invented a new terminology, the syndrome. In other words, the syndrome is extended to any condition of congenital heart disease in which there is a defect, a communication in between the right and left with pulmonary hypertension. So, Eisenmenger syndrome is pulmonary hypertension due to a high pulmonary vascular resistance with reversed or bidirectional shunt at the aorta, pulmonary, ventricular, and atrial level. So he absolutely accepted, he was an hemodynamic investigator as well, but he accepted the interpretation being made 47, 9 years before. Okay? So, and that is. The pathologist then made a major contribution. It was from, it was English, Edwards was American, and they advanced the classification of pulmonary hypertension. That is grade 1, hypertrophy of the media, grade 2, proliferation of cell proliferation in the intima, grade 2, fibrosis and obstructive fibrosis of the intima and the lumen. The grade 4, you see here, the rupture aneurysm, plexiform lesion, glomoid lesion, and the necrosis, fibrinoid necrosis. Well, remind that the first patient of Victor Eisenmenger indeed died because of hemoptysis, which means that the disease may be so severe with necrosis, the malignant, you remember the kidney, malignant hypertension, fibrinoid necrosis. The necrosis may rupture the vessel wall and account for hemoptysis and death. So you see here, for instance, another example that this is the Wincher tree aspect of the pulmonary vasculature with truncated arteriole, a small vessel because obstructive vascular disease. But what I want you to draw your attention here is that it may be so severe that there is arteritic there is a necrosis in the wall. Maybe that it is a cancel the major part of the wall, and then there is a formation of aneurysm, plexiform lesion, or glomoid lesion. Indeed, this is quite similar to a glomerulus in the kidney. Well, and this is the consequence. Again, hypertrophy, proliferation cell, proliferation fibrous tissue, arteritis, rupture, or from aneurysm with plexiform glomoid lesion. Okay, so what is happening indeed in these patients with pulmonary blood overload? That there is an extension usually of the musculature. A difference from the regular baby, when there is a regression of the muscular hypertrophy of the distal arteriole, which accounts of the hypertension during neonatal period or during fetal period, with thinning all the wall, that accounts for low pressure in pulmonary vasculature. There is a low pressure. Okay, what is happening indeed is that we have an extension of the musculature in the distal bronchiole and arterioles, and hypertrophy, and then all the pathological phenomenon leading even to fibrinoid necrosis. So let me show my case now. I want to show you what is indeed a case Eisenmenger syndrome, still existing in nowadays 1 century later, because the disease did not disappear. It is still existing. So look at here, 18 years old, male, autopsy diagnosis, congenital heart disease with a huge perimembranous ventricular septal defect, dextral position of the aorta, atherosclerosis of pulmonary artery, Eisenmenger complex, okay. Watch glass nails, clubbing, Hippocrates fingers, pneumonia of the right middle lobe, lung emphysema, spodogenous spleen, because there was a pneumonia, follicular splenitis, nutmeg liver, congestive heart failure in the liver, subacute, kidney tubular necrosis. But again, malignant pulmonary vascular disease with plexiform lesion and fibrinoid necrosis. Let me show now. Here is the Eisenmenger complex. You see, there is a huge perimembranous ventricular septal defect close to the membranous septum, and the aorta is overriding, that is rising both from right and the left ventricle, and this is the ventricular septal defect seen from the right ventricle. But look at here, look at here. How much thicker is the right ventricle? Is it thicker like the left ventricle? No, certainly there is a hypertrophy there, but not so huge, because there is this reverse shunt there. And the pressure in the right ventricle is systemic, but not suprasystemic. So it cannot be so huge, the hypertrophy. When I was Leo, because he dictated the title, remodeling of the heart and remodeling of the pulmonary vasculature, remodeling of the, how much big is the right ventricular hypertrophy there? It's not so huge. It will be different in idiopathic pulmonary artery hypertension. So look at here, indeed there were some plaques, some 4 fatty streak there in the pulmonary artery, okay? But when doing the histology of the lung, it was really impressive. The vessel was mostly closed, almost closed, and there was fibrinoid necrosis. We did we published years ago a paper, very important paper to my mind, cases of Eisenmenger syndrome who died spontaneously in the natural history. And in any case, we realized the existence of very, very advanced malignant disease. So fibrinoid necrosis is unfortunately the end of the story. So, okay, which are the diseases at risk of Eisenmenger syndrome? Any disease that present with septal defect at the atrial, ventricular, and arterial level. So atrial septal defect, atrioventricular septal defect, ventricular septal defect, truncus arteriosus, aortopulmonary window, and patent ductus arteriosus. So let me show you here. This is a normal heart. Completely divide the two compartments, right and left. But there are cases indeed in which we find a huge atrial septal defect, fossa ovalis type, ostium secundum here, or ostium primum, the setting of atrioventricular canal defect with the split of the anterior leaflet, the cleft of the anterior leaflet of the mitral valve, the complete atrioventricular canal, in which indeed there is a communication in between the atria, interatrial, but also interventricular below the common AV valve. So this is a huge, absolutely huge septal defect in the core of the heart. And this is the ventricular septal defect, again, very similar to the one of Eisenmenger complex. This is the truncus arteriosus, undivided great arteries in which there is a ventricular septal defect below the semilunar valves, but there is also a communication in between the aorta and the pulmonary artery over the semilunar valve, the common semilunar valve. This is the aortopulmonary window in which the great vessels are separated at the root, but there is a communication in between here at the tubular part of the aorta and the pulmonary artery. And finally, the ductus arteriosus. I must say that I have seen cases of Eisenmenger syndrome in persistent ductus arteriosus as well. But recently, not years or centuries ago. They are not in the collection of museum of the Pathological Anatomy Institute seen many, many years ago, in my own professional experience. So, in conclusion, congenital heart disease with left-right shunt. Okay, we have a pulmonary blood flow overload, pulmonary vascular disease, increased pulmonary vascular resistance, reversed shunt right-left, cyanosis. At this time, there is no other way to take care of these patients probably but the lung transplantation. But what is funny is when you do lung transplantation in these patients, you can leave their own heart. Just you close the ventricular septal defect because the heart is working perfectly. It's even hypertrophied. Is an athlete heart in terms of mechanical function. You have to change at least one lung, okay? So finally, and this is of course, it's a very banal diagram that is, at the beginning you had left-right shunt because there was low resistance at the pulmonary lung vasculature, and then you have the reversed shunt or mixed right, left, left, and right. I want to finish my presentation briefly with these couple of slides. That is, what is the natural history of the disease? It's bad. You have a 3% year of fatal outcome. So, and I want to show you that the risk is better, I must say, than in idiopathic pulmonary hypertension. In idiopathic pulmonary hypertension, as you see here, okay, the mortality is 50% within 3 years. Whereas in Eisenmenger physiology, you see that it is 3% per year, which means that in, of course, you will have in 20 years, unfortunately, you have a very similar 60% mortality in 50 years. Last, look at here. I mentioned to you before the problem of remodeling of the right ventricle in pulmonary hypertension. You remember that the hypertrophy of the right ventricle during in the setting of Eisenmenger syndrome is, yes, is important, but it's not so big. This instead is a case of idiopathic pulmonary hypertension in which there is no ventricular septal defect. There is no possibility of blood escaping from the right ventricle to the aorta. This is a situation of hypersystemic hypertension there. That is, and so you have the equivalent of hypertrophy in the left ventricle with pulmonary, with aortic stenosis or with coarctation. And you see here, indeed, hypertension is a risk factor of atherosclerosis. As this is the only condition in which, is a Menger syndrome, pulmonary idiopathic pulmonary arterial hypertension, atherosclerosis may occur also in the pulmonary arterial bed. Thank you very much indeed.
Thank you very much. Any question, comment? Leo, please.
Well, if we had a model of an inspiring lecture, Gaetano, I think you gave it. So thank you very much, particularly for the imaging. Now, you correctly, as a pathologist, describe the morphology, the history, the development. But if you had to predict when this happens, is it
yes.
What might be the event that triggers this? Is it genetic? Is it mechanic? Is it when is the, you know, if you had to dream
yes.
to make an early intervention, when would you do it?
Well, that is an absolutely important question. First, you have to divide the risk in between before or after the tricuspid level. Certainly, the chance that occurs distal to the tricuspid valve are associated with earlier occurrence of pulmonary vascular disease. So, patients with ventricular septal defect, truncus arteriosus, atrioventricular canal defect are at risk of very early pulmonary vascular disease. How much early? Big problem. That is, we realized, we thought years ago that was a problem of time, years. No. In a ventricular septal defect, truncus arteriosus, or atrioventricular canal, it may occur within 1 year, 1.5 years, 2 years at the maximum. So now the must for surgeon is to operate this patient within 1 year of age. And the problem is solved. The problem is solved if you operate as more as possible within 1 year. So this means that the Eisenmenger syndrome occurs very early in the natural history of disease. Fortunately, we have a cardiac surgery nowadays that is available to make operation even in very pediatric infant age.
Okay, I think we have to move. Thank you again a lot.